It's wonderful to have the opportunity to address French-speaking colleagues in this conference who study psychological trauma and dissociation. My presentation will focus to the most complex consequence of developmental traumatization, namely the dissociative identity disorder. I will address in particular the discrepancy between clinical appearances of the disorder, I mean the surface, the clinical surface, and the inner experience of dissociation, the core experience. The surface, the clinical surface may change over time between cultures, among individuals, in the same individual over time. However, the core experience is more or less the same. That is the disturbance of sense of self and agency. Because of this discrepancy, dissociative identity disorder and its partial forms remain hidden in clinicians' eyes, despite the current epidemics affecting individuals from a broad range of age, young adults and adolescents in particular, as well as children. These patients may get psychiatric diagnosis other than a dissociative disorder, depending on their predominant symptoms. For example, young adults with dissociative identity disorder usually suffer from chronic double depression or may demonstrate features of borderline personality disorder. Others may come up with persistent functional somatic symptoms, a brief psychotic attack, or just a milder nervous breakdown. Last but not least, chronic suicidality and self-destructive behavior are common, all being enactments of unprocessed developmental trauma. Traumatized dissociative children may be diagnosed as having disruptive mood dysregulation disorder, attention deficit hyperactivity disorder, or conduct disorder. Adolescents may be taken as suffering from a bipolar mood disorder or just having a normative age-related crisis. Obviously, such preferences have consequences about early intervention and effective treatment of these conditions. To make an accurate diagnosis, one has to conceive the bigger picture, I would say. I mean the overall gestalt of the symptoms rather than narrowly focusing on a single aspect of the suffering. And most importantly, the inner experience of fragmentation should be inquired, which may be difficult for the patient to articulate. This is about getting estranged to oneself and being intruded, interfered, and even controlled by distinct mental internal entities inside, which are typically experienced as not me. They all occur without being delusional. Daily amnesias or memory gaps may accompany these experiences. The treatment of DID, dissociative identity disorder, should be re-establish the synchronicity between such distinct perspectives in one's internal world, as well as the synchronicity of this inner system with external reality. Healing can be achieved by good generic psychotherapy, considering the diagnosis and the particular patient's needs. Clear-cut psychotherapy paradigms implemented in a rigid fashion usually do not work well. In the final analysis, treatment of dissociative identity disorder examines the genuineness and creativity of the therapist, which cannot be replaced by any other skill.